Welcome to another edition of the Corner Booth Podcast here from the Snowdon Deli. I'm Aaron Rand from CJD, along with Bill Brownstein of the Montreal Gazette. And our guest today, a family medicine practitioner, Dr. Laura Sang is here. Thank you so much for being here. I should mention you practice in St. Hippolyte, so you're not in the city. Conscious decision that you made, and we're going to come back and talk about that. But ostensibly, we're here to talk about all the controversy over the past couple of weeks now within the healthcare system, the OQLF directives, something that was concerning enough for you that you wrote an op-ed in the Gazette to talk about this and basically say you were concerned. So why the concern? Why the need to kind of vent?
So my biggest concern is really that, our healthcare workers are already in such a fragile place that there's already people leaving for retirement, for burnout, for so many different reasons. And I was concerned that just adding a potential other barrier might push more people to leave when we're already struggling with retention of different healthcare.
All right, so look, I want to ask this question because, and I know it's kind of an interesting time to be doing this. We found out actually just this morning that the three major, if you will call them, ministers responsible for the healthcare sector. So you have the language minister, the health minister, and the minister responsible for relations with Anglos, saying there's nothing to worry about here. I had you read the article before we came on. In having read it, does that change anything for you? Do you feel better, safer now, less concerned now having read that?
I'm happy that there is a response to, some of the concerns that have been addressed. I would like to see a little bit more of a clarification on what exactly this means, and I would like to have a chance to, at least see a summary of that 31-page document that was kind of
the directive
outlining.
Well, it's very simple to say in 2 paragraphs that all will be good and all is wonderful, but 31 pages of the directive suggests otherwise, which makes it very, very murky for an awful lot of people because the fear factor is way up there. People think they'll need a certificate like they will for going to school, a directive saying that I'm an Anglo and a historic. I mean, it just got so strange, and yet they put out 2 paragraphs and say all is good, nothing to worry about. So the thing that you have to, I guess, what concerns people, what was the need of the 31-page directive in the first place?
Yeah, I think it's a bit of a, confusing situation for everyone. And what's interesting is since all of this has come out, I've talked with a numerous number of colleagues that I work with in, rural regions. And this hasn't been anywhere in the French news headlines, which I find kind of interesting. They seem to be aware of it. And I would like to hear the opinion of all parties involved. And I would like to hear what, our Francophone physicians feel about this.
What's interesting is that to let people know, you work entirely in French, and like you've gone on record saying you love Quebecois culture, you love the French language, you have no qualms whatsoever, and that's not your concern. I mean, in terms of like dealing with people, you have no problems whatsoever. Your concern is that people have to understand the nuances when patients come in, and malheur is not a heart attack but a stomach ache, things like this. And I mean, whether it be French or English, and your concern is a lot of things will get lost in the understanding of how patients report things if they're not allowed to communicate in their own language, be they French or English or whatever.
Mm-hmm. Yeah, I mean, just on my day-to-day experience, it's a struggle to, get tests done, get people seen by specialists, just getting, the basic things and getting that flow through the system that you want. So anything that, kind of ignites any kind of concern or feeling under scrutiny or whatever, it makes me worry that people might just pack up and leave if things get too complicated or there's even the threat of something like this, even if it's not what's actually happening.
So what's interesting to me, having read the letter today from the 3 ministers, there are a couple of words in there. People talk about things that are ambiguous. The one word that strikes me is may. You may provide service to someone in that language, in this case in English. Doesn't mean you have to. It almost like it gives you the option as a provider to speak to them in English or not based on what you feel like or don't feel like that particular day with that particular patient. That's concerning to me. And the other part is the key thing they seem to say, it's not our intention for this to create a problem and not to allow for people to be served in English. Well, it may not be their intention, but the directive certainly seems to lay out a set of rules where people working in the sector have to follow those rules. If you don't follow a directive, my understanding is you could actually lose your job. Is that not accurate?
I have to be honest, I've seen sort of a few different takes on it, and I think that that is on the more extreme end. I think that there's sort of a spectrum, and from what I've understood, it's also a bit on a case-by-case basis. I certainly hope that that's not the case, given how precious a resource healthcare workers are.
To another point, and maybe that's important to bring up, part of why you've done this and reacted this way is because of what's actually happening within the healthcare system, where doctors, and we know this, we know we're short at least over 1,000 doctors in the system. And the concern now is too many people are leaving the system. We already know that people leaving public to go private, that's a concern. The government is, I think, trying to address that. But other people who are just simply deciding, I've had enough, I'm retiring, I quit, and they don't get replaced. And that's a concern for you.
Absolutely. The rate at which people are leaving for a variety of reasons seems to be faster than the rate that we can replace people. And things like the GAP, that program that was put in place to try to, give patients access to a family doctor when they don't have one. That's a great opportunity for someone who, is on the brink of retirement or is having some health issues and has to reduce their practice. It's still a great way for people to, be able to continue to work and serve the community. And I think that, any kind of regulations that threaten that, or any kind of talk of cutting things, or any kind of negotiation that takes place without consulting the people involved is directly a threat to the people involved.
And there's enough angst on the plate for most physicians anyways in terms of the healthcare system and everything else. I think the last thing a doctor needs is to worry about whether or not they're doing the right or wrong thing by speaking to someone in a language that may or may not be approved of by government forces. That could really, add to the all sorts of mental strain, I would guess. And I guess if you have your doubts about retiring, this might push people more in that direction if you don't want to deal with these kinds of hassles.
Yeah, as a family doctor working in the public sector, we're already held to quite a few restrictions. So there's something called the PREM, which is pretty much a permit to practice in a given region. And within that region, you're held to what's called AMPs. These are specific activities that are mandated by the region that you have to do for a minimum of 12 hours a week, and you get to pick from a list and change every 2 years as needed. But any kind of non-adherence, if you do too much work outside of your region or you don't respect your AMPs, that already leads to a 30% pay cut. So there's already enough punitive measures in force that a lot of people are frustrated by, and it can be a real struggle in that I want to have more walk-in availability for my patients every day if I could, but because I'm split working in 2 different locations, when I'm not at the internal rehab center that I work at, my inpatients have to be cared for by one of my colleagues. And then when I'm not present at the clinic, if there's sort of a walk-in emergency, it's my colleagues who have to see them. So just being forced to work in 2 places already puts a strain on me, and I have to try to compensate in both settings to make sure that the standards of care are withheld, that people are getting seen within a timely fashion, that issues are getting resolved, etc. So it's already challenging enough as it is just with that. So adding any other kind of, barriers or restrictions or things, I think for some people that could be their breaking point, and it wouldn't be by choice. I think a lot of people don't want to leave. We want to make it work. We want to be able to stay and work in the public sector and serve the community. But it's just getting harder and harder, and especially as more physicians, kind of leave the system, you're having a greater number of sicker patients falling on fewer people to care for them, and that puts a strain on those people as well.
I wonder too, one of the things, just to get back to this whole directive, the OQLF directive, anecdotally, so we had I spoke to people this week who called into the show and asked them for their experience. Has anything changed in the last couple of weeks if you've been to a hospital, been to an emergency room? And I'm going to say, surprisingly, they were all served in English. I might have taken one call from someone, and it might have been at a hospital in La Chenette, who had a little trouble getting English spoken to by a doctor, but everywhere else, regardless of the hospital, they were spoken to in English. And then I thought to myself, well, it seems to me this directive, beyond just the patient and doctor, concerns people just working amongst themselves within a healthcare facility. So you're an Anglophone, you work in French, but to everyone else in a facility like that, does this concern you in terms of you have to be speaking French to everyone else you deal with. I'm talking patients aside. And if you're not, you could get in trouble. That's what it seems to me this is also.
Co-workers,
right?
I mean, nurses.
Is that part of it? Do you take that from this?
I think, again, it's a bit of a gray zone
Yeah.
depending on how it's interpreted. And, it is possible. I like to give people the benefit of the doubt that maybe there was something that was lost in translation. I'm open to hearing more and getting that clarification. But I think that that's a boundary that, doesn't need to exist. We can let people speak in whatever language they feel comfortable amongst each other. I think that's so important to have that kind of communication between different healthcare providers, because that leads to cohesion, that leads to, team building and stronger team management. And if your team is stronger, your ability to work together and care for patients is that much better. So if you have a good rapport with the nurses and the other professionals that you work with, if someone notices that something is off with a patient or that there's an error or whatever, you can work together so much faster to correct that. Whereas if even just with the threat of this kind of law is in place, it might make people kind of hesitant to talk with each other. It might create barriers to communication. And we saw especially how there was such a decrease in connectedness during, the pandemic, that because of so much being done on Teams and remotely, that I know I felt as a resident at the time that I missed my colleagues. I felt lonely. I felt disconnected. So being able to communicate with someone and connect is important, not just for the patients, but for the healthcare team itself.
Maybe it begs the question, has it been a problem up until now? Is this a solution to a problem that doesn't exist in a sense? This idea of being able to deal with your team, to deal with people in whatever language they feel most comfortable in. Have you ever run into that? Has that been an issue?
I mean, I personally haven't seen it as much of an issue, but that's also because I am bilingual and I can work in either language. But I know that, for example, people doing locums or going on rotations in certain places, if they are Anglophone and it's a primarily Francophone area and that their French isn't as strong, it is a bit harder to connect. It's harder to socialize. There can be some barriers. I can't speak on anyone else's behalf but mine. But I think what is most important is that people can get care in a common language, that your healthcare provider and your patient are able to communicate with each other in a way that is effective. And, if you require the need, sometimes I use Google Translate to help with patients, because sometimes at the rehab center we have people that are, unilingual Arabic or Italian or whatever. So we do the best that we can. And you have to go that extra mile using a translator or using any kind of assistive technology to really make sure that nothing is lost in translation. And you have to change the way that you're, doing your questioning, and that takes more time, but it's worth taking that time, and it's worth accommodating someone to make sure that they're getting the best care possible.
The Corner Booth podcast is brought to you in part by the Snowdon Deli, serving Montrealers since 1946 and home of the city's best smoked meat sandwich, the Snowdon Deli, DeCarry Boulevard, north of Queen Mary Road.
I would think that you'd be a poster person for our health department here. I mean, you're someone who grew up in Montreal, you're an urbanite. Forget language, like talking about they want people like from here to want to go to the regions more, and you opted on your own to go to the Laurentians. I mean, whereas a lot of people that you grew up with are doctors here probably wanted to stay in Montreal. I mean, for family reasons, for all sorts of reasons. And, being an Anglo or a Franco doesn't seem to be the issue, but you would think that they'd give you some sort of medal or something for that, because honestly,
you're a unicorn,
No, but how many, you don't hear it, but the whole problem, you were talking about all of that. I mean, that's such a problem getting people, Laurentians, okay, not far, but going way out into the region. So, and you think, has that made a big difference? And what made you opt to want to do that, like to get away from the city and to do this on your own?
So I know for me, I grew up in Montreal. I thought I was going to be a Montrealer forever. And then, the pandemic happened and I ended up doing a lot of rotations in rural areas. And I realized just that slower pace of life, doing the exact same work, but just in a calmer environment, made me feel like the best version of myself. So I wanted to be true to myself. And, there's so much access to nature in the Laurentians. There's so many different things, but it's still close enough to Montreal that I can come in and visit family and friends. So it was sort of a good happy medium. And what I love is since moving out there, I've joined a choir in French. I've slowly built up my hobbies and I've made friends. And I've just been able to immerse myself in Quebecois culture and just fall in love with it even more and finally get to know the music and have that sort of relationship with the language and culture that I've been looking for such a long time.
I think you're right, Bill. There's your poster child for the Quebec Healthcare Department,
No,
right?
and as you point out, you want people to embrace like Quebecois culture, French culture, and all the rest. But when you, as you pointed out in the op-ed piece, is that at the risk of what does that have to do with like the language in which you serve like patients? You don't think that should be effective? Like it's not helping the language, the French language, by denying people the right to speak in the language that they choose to.
I think, learning more languages should be embraced.
Absolutely.
Point, right? I think that it's such a wonderful gift to be bilingual, and I wish I could learn more languages, but there's only so many hours in a day. But for me, it happened because I wanted it to. I made this choice and I made it work within my practice. It wasn't because anyone forced me. It wasn't because I felt pressured. If anything, it's sort of the opposite, a bit of a reverse psychology thing, that the more someone feels forced to do something, the more it may feel like a chore and that they may resist. So I think what should be done is sort of providing incentives and, providing a whole different, using the carrot and not the stick.
Right.
So to speak.
If I can ask, just in more of a global sense, we're talking about the fact you're in family medicine, and we know the biggest problem in Quebec right now, healthcare-wise, is people choosing not to go into family medicine. Why do you think that is, and what can be done to fix that, to change it, or we just was stuck with this because too many people decided to leave the public sector to go private, or to actually go into specialties now because it's more lucrative? Why do you think this is happening?
So there's a lot of different factors that play into why, people are not choosing family medicine as much as they used to. I think the first one is, when you go through medical school and residency, you're a bit of a fly on the wall of seeing what your life is like or what your life could be like by what you see around you. So you see the experiences of other students, other residents, staff that are working in that environment. And one thing that I saw a lot in family medicine was people didn't have as much control over their hours as they wanted to. There's a lot of, there's a huge administrative burden in family medicine, because if you think of, any specialist that a person goes to see, oh, well, if it's outside of their scope, we'll go see your family doctor about this or that. Anytime someone needs any kind of forms filled out, like the driving forms for the SAQ, if you need, handicap parking, if you need any kind of disability tax credit with the federal or provincial government, like all of that comes to us. So we have to find time to kind of fit in those forms, while at the same time people are followed by so many different specialists. You need someone who's kind of putting it all together, because one person changes one medication there and then they go see someone else and that changes. So it's such a big job of kind of trying to put everything together. And there is a lot of work that we do that is not paid. So yes, you can bill for calling a pharmacist outside of your clinic, or you can charge for forms. But the inundation of lab results we get, consult reports, different clinical reports, like going through all of that takes so much time. I think on average it's something like 20% of the family doctor's time is just spent going through paperwork and that sort of thing, and that's time that's not paid for. We have such an important job, and there's a big discrepancy in terms of the amount of money that family doctors make compared to other specialists. But I don't even think it's about the money. I think it's really about the working conditions and the recognition that just the way other specialists sometimes talk about family medicine, just in passing, that they've sometimes put it down, and learners are very perceptive and absorb that. And
Right.
If you're not showing family medicine the respect that it deserves, if you're telling someone, oh, you want to just be a family doctor when you could be so much more, family doctors are incredible. We are sort of the foundation of the healthcare system. We are sort of that commonality when someone is seeing so many different specialists, being hospitalized.
No kidding. How many
etc.
people are looking for a family doctor?
Exactly.
I mean, the demand is huge.
And what's incredible about, family medicine is when you can actually, follow an entire family over long periods of time. You get to know their dynamics, things that might be specific to the family. You get to know sort of the family history, how things evolve over time. If someone passes away, you understand the context in which that happened because maybe you were involved in their care. And then, you're managing the grief with the other family members. Like, it's such an incredible and unique relationship that you don't necessarily get with other specialties. And I think it is so important for that longitudinal follow-up to, do as much preventative medicine as you can so that people can stay as healthy for as long as possible, especially now that we're living longer. If I can follow someone who I know has a family history of diabetes and catch diabetes early and manage it well, that could save a foot amputation down the line, which is a huge personal cost to that person, but as well as our healthcare system.
So a couple of things. Number one, to hear you speak of family medicine that way, you've outlined the problems and the difficulties within the system. That sounds pretty grim because we know fewer and fewer people want to go into this particular discipline. How does that get fixed? I mean, the government knows this is going on. And I hear, not just in healthcare and education, a lot of other places, how much the bureaucracy slows things down. And clearly that's the case in medicine as well. All this red tape that you have to go through just to be able to get things done, to fill out forms. Do you see this changing? I mean, enough doctors are speaking out about this. Are you confident that it'll change in this new organization of Santé Québec? Do you see anything changing?
I think, at some point things will have no choice but change to be able to uphold the standard of care. I think that a really good place to start would be with more flexibility with the PREMS and the AMP system. I know that when I was looking to apply for my PREMS, some places only had one spot. And when I went to visit them, they said, well, every clinic I went to, I must have gone to about 5 in one of the regions. And they're like, oh, this doctor's retiring, this doctor's retiring, yet there's only one spot. And, there are a lot of consequences to working outside of a PREM, so it's something you don't want to do. So just restricting where people can practice, and even within the island, everyone moves around. Montreal is such a sort of melting pot, and you live in one area and you work in another. So I understand initially the PREM system was put in place to try to distribute physicians sort of efficiently, but if you're struggling to get a PREM in an area you want to work and in a practice that you want and in line with sort of your expertise and your areas of interest, if that becomes too complicated, people are going to be like, well, you know what, I'm just going to go in the private and then I can do medicine the way that I want to.
Yeah.
So the more flexibility that you can have with these PREMs, instead of penalizing people, incentivize it, make it more flexible, offer instead of mixed AMPs where you have to work in, at least 2 places, offer more single AMPs so that people can better structure their schedule and work hours and meet the demands. It helps so much if, you have just prise en charge AMPs, which is kind of taking on patients in like an office-based setting in a GMF or other kind of clinic, because if you can be there 5 days a week, that's that much more walk-in services that you can provide, that much more appointments. And if you can catch someone at walk-in, with the start of a pneumonia, you can prevent them from having to go to the ER and get hospitalized and need more intensive treatment. So I think the more that we can focus on that preventative care while simultaneously supporting family doctors, nurses, other healthcare professionals, that would make a huge difference in at least retention. And then as you see that people who are retained are happier, they're less burnt out, they're able to do their job, we've removed those barriers, then I think naturally more people who are already interested in family medicine but had their reservations would be much more willing to join.
There's also a big push, this is a final question, a big push now for the government to recognize that people leaving the public sector, going into the private sector, is causing a problem. Bill talked about people now choosing to go become specialists in medicine. Is that something that you think, and I know the government has talked about this, I'm not sure what we're doing about it. We've lost so many nurses that have gone from the public sector into the private. We're understaffed. What needs to happen there? Should there be, in your opinion, a rule, a regulation of some kind, not allowing you to go private before serving X number of years in the public system?
I think that's a bit of a negative slant to it. I know from my anecdotal experience in talking with nurses that a lot of them who have left, it wasn't a choice. They wanted to stay, but they just couldn't. They were on the brink of burnout. They just couldn't sustain working in their environments when you have forced overtime, double
Right.
shifts, when you don't get, breaks to eat, bathroom breaks, vacations, sick days. These are things that are essential to keeping people healthy. And especially, in sort of these like high stress areas like the ER and the ICU, you want to make sure that you're taking care of the people who are taking care of the people. So I think instead of trying to, regulate like, oh, you have to do this many, years in the public sector before you're allowed to go private, make the public sector appealing, make it a safe and, healthy and happy work environment. And then you'll have people who won't be trying to leave.
But we're in a very unique situation here. In Quebec, it's one of the very few places where you can be private one day and be public the next day. They bounce in and out of the system, and which I find kind of strange because at whose expense? So like when someone decides to go private a couple of days a week to do things and then join the public side, how is that good for the system?
Yeah, for physicians, unlike in other provinces, you have to work either in the public or in the private.
Right.
You cannot
do both.
And there is also a limited number of times that you can switch back and forth. I'm not sure how that is for other healthcare professionals, but at least for physicians. So most people tend to start out in the public and then go back to the private, or it's kind of variable.
It's like a juggling act.
Journey, exactly. But I think if you can make the working conditions safe and manageable, and that people can enjoy their work and they're not just running around trying to put out fires, and that they have moments to, chat with a colleague, to eat their lunch, to be able to sit down, to just, have basic human needs met, you'll have much less people looking for something else, because what we'll have will be good enough. It will be stimulating enough and safe enough.
I want to thank you so much for taking the time to be with us.
And driving in from the Laurentians on a very rainy day.
And hope that we do get that clarification that we're all looking for with respect to these new directives. Thanks so much.
Thank you.
That wraps up this edition of the Corner Booth Podcast. We'll see you again soon.